Health and Wellbeing Board meeting, 24th of September 2020. Couple of meeting protocols. For the duration, if you can, remain on mute, please, unless asked to speak by the chair. If you wish to access the board, click on the raise hand symbol and we'll invite you to speak. So thank you for that. We have a list of apologies. Kathy Hadley, Teresa Grant, Nick Adderley, Assistant Chief Constable James North will be replacing, joining at 11 o'clock. Stephen Mould, apologies, Alan Burns, Francis Shattuck, Kushni Waring, Maria Wogan is joining, and Alison Gilbert, Tim O'Donovan is joining in replacement. Toby Sanders, Councillor Matt Golby and Councillor Fiona Baker. Item 2, notification of requests for members of the public to address the meeting. There have been none. 3 declarations of interest. So this is my chance to invite board members to declare any disclosable interest. I'll assume that there are none. Thank you very much. So item 4, the minutes of the meeting on the 9th of July 2020. So I'll invite the board to agree the minutes as a factual record. Okay, thank you. There are some actions arising from that meeting on the 9th of July. Lucy Whiteman, Peter Lynch and Cheryl Bird to review the joint NHCP Health and Wellbeing Risk Register. Once the Northamptonshire Healthcare and Wellbeing Plan is published. Well, that's on hold, I'm afraid, due perhaps understandably to the COVID-19 response. The publication of the draft plan has been put on hold and we'll return to that hopefully sometime early in the new year. Another action, Ian Currier, new chair of the Children's Trust, been invited to become a member of the board. Well, that's all water under the bridge. Ian was invited and accepted the invitation, and Ian has since resigned as chair of the Children's Trust. A new interim chair, Claire Chamberlain, is unable to attend today, but will try to attend the next meeting on 14th of January. The only other action there was a letter to be sent to the source of the DFG funding to highlight the risks or the risk posed by not being able to spend that money, that DFG allocation, by the end of March 2021. That, folks, is in progress. A draft letter is currently being reviewed by the chief housing officers before being approved by the chair and the board. Yes. Somebody want to come in on any of that? Cheryl, is there anybody wanted to come in? I can only see part of the screen, I'm afraid. No, okay, right. Thanks, folks. We'll move on. So item 6 is board member updates. There are a couple before I invite colleagues to update us on with respect to their organisations. But changes to board membership. Paul White has finished his term as interim chair of NHCP, and recruitment is currently underway for a new chair. Alison Gilbert will be the NHCP representative on this board until the new chair is recruited. Jonathan Ireland, Dr. Jonathan Ireland is retiring in November. So Jonathan, this is your last meeting. I'd like to thank Jonathan on behalf of the board for his work and Jonathan, your commitment to improving the health and wellbeing of local residents. You may wish to comment on that. But other than that, it's open for discussion for the rest of the board members to share updates. Any updates on offer? Okay, very silent.
Hi Nick. I'm not sure how I raise my hand, Nick, on this, but
do it analog.
Sorry?
Do it by analog. Just do that. That's fine.
Okay. I'm doing that. Hello. Yeah, so thanks for your kind words. Yes, retiring in November. I hope that my replacement will be able to carry on representing GPs on this body. And it's been a pleasure working with you all. I hope that this forum can continue to engage with everybody and provide support for health and wellbeing in the county. In terms of general practice, one thing we have set up is a GP board for the Health and Care Partnership, to try and integrate better with the ICS, which the difficulty being that GPs are a more disparate group than the other units, such as the trusts and councils. And what we've done is try and amalgamate the PCN clinical directors, the federations and the LMC into one body, so that there can be a united front and voice, so that there isn't so much confusion about who to go to. So the idea is that that body will kind of have a cohesive function, and people will feed back into that. Everybody who joins various committees will represent all those groups and all GPs in the county, so that hopefully that will give a better voice and, as I say, support for the ICS.
Okay. Thank you, Jonathan. Might be worth just checking, does everybody know how to raise your hand in using Zoom? Because I'm assuming that you do. If not, maybe we'll pause briefly for a tutorial. If not, we can carry on. Any other updates from board members? I'll just throw in a brief one into the ring then, to do with the university. We have reopened, so we're expecting, well, we never shut basically. We had 500 students in residence all throughout the summer, but we're having thousands are turning up presently, enrolling from not just the UK but overseas. So clearly that's there's a potential COVID risk there. Just to reassure members that we've been working since April with colleagues in public health and on the local resilience forum to make sure that we've got in my opinion, a very well rehearsed COVID secure environment. Maybe you've heard in the news this morning, University of Glasgow just had 100 plus students with that local outbreak. Chances are that will happen at our campus. I'd be surprised if it didn't, bluntly, up until Christmas. But we have all of the measures in place to be able to contain that likelihood if it does indeed happen. So just to assure members that we are all over this, like a rash. That's a rather important phrase. But I would say that we've had, get slightly off the record, but not that much help in support from the central government in how we manage this. So I just thought I'd leave that one there for you. We've just got on and done it ourselves, by and large. Any other? Okay, let's move on then. So that's board member updates. Item 7 is North Hampshire Health and Care Partnership updates. I'd like to invite Tim O'Donovan to introduce the update from the NHCP. Tim.
Thank you, Chair. I'll take the paper as read, but if I may, Chair, just bring out sort of 5 key points, really as way of update to the board in terms of our journey towards an integrated care system for 2021. So I think first point really, Chair, is to reflect on the receipt of the phase 3 letter. So I think since we last met in July, we've received the letter from Simon Stevens and Amanda Pritchard around the requirements for the next phase of management of the pandemic, one of which has really explicitly referenced that the full coverage and the LTP commitment for integrated care systems for April 2021 remains. So there's probably conversations around whether that stayed or went or was accelerated as a result of COVID, and very much the narrative is for full coverage of ICSs across England by April 21 still remains. So just to note that there are 18 ICSs in the country thus far, and there's 26 left, and we're one of the 26 in Northamptonshire to go. So between now, September to April 2021, we've got some work to do around developing what that means for Northamptonshire. Section 4 of the paper just highlights the sort of national process and timelines with regards to the sort of gateway approval process for this. So it's a national process, and just to note, the key dates for the board are approval gateways at November 2020 and February 2021. And for Northamptonshire, we're targeting February 2021, and I'll come on to the rationale of why we've chosen that date as a system and partnership. Section 3 of the paper touches upon some of the minimum requirements and sort of maturity elements of an ICS that will need to be satisfied and demonstrated and evidenced within our submissions and plans going forward. I won't read them out, they're contained within the paper, Chair. Happy to take questions after that. Section 5 of the paper discusses, I guess, our approach, our local approach to the programme, ensuring that we hit all of those markers in terms of those requirements. So in the paper, you'll see a figure diagram of 5 component pillars or pillars and components really of how we're going to get there. And there are plans behind those 5 work streams. And the 5, just for clarity, are: 1, learning from COVID and the recovery from COVID-19. 2, the system architecture and leadership, so very much these sort of governance arrangements across the system. 3, population health management, the data insights, the information and data flows around, and I know we've talked many times about that, Chair, around how that can help support the different levels of system across Northants. And 4 and 5 are around strategic commissioning and what that means in terms of not just the NHS, but across the local authority and with regional colleagues within NHS E&I. And the 5th component is the integrated delivery model. So how are we going to actually deliver services in a new ICS structure? So what will happen at a county level, what will happen at a place level, sort of coterminous with the unitary footprint, and what services will be delivered at more locality and neighbourhood level. So so that's highlighted in the paper, and we've submitted a draft development plan to NHS E&I on the 2nd of September that highlights our sort of local approach. Section 2 of the paper then, and the last point really, is to highlight what we've achieved. So we've achieved a great deal in terms of some of the requirements that are needed for an integrated care system. So one of the elements will be around a single NHS commissioner across the county. We now have that in terms of Northamptonshire CCG. We've moved towards developing a group model between Northampton General and Kettering General, so good strides and positive strides in terms of that integration agenda. And obviously we've got an integrated community and mental health provider with NHFT, and established 16 primary care networks, and as Jonathan said, a framework of support around primary care moving forward. So a lot of positive, I guess, form movements, and I guess the last point I want to just touch upon is the rationale for February 2021 and why we've decided to aim for that. I think it's recognised within our development plan that the sort of mantra between sort of ICS is the level of collaboration between the NHS, local authority and other partners. And I think what we need to do still, and we've identified through our development plan, is we still need to work out what we mean by that closer collaboration and how formalised that is. That's still to be determined. So while we've made great strides, there is that ongoing conversation we'll need to continue to have September, October, November and December to really be clear about what that looks like. And then obviously how that hardwires itself in terms of the role of the ICS board, this board, all of the governance that needs to be sort of hardwired together and really brought together will then need to be solidified and agreed around what that level of collaboration looks like. But I think all members will agree this is a sort of a great opportunity to really galvanise across sort of different levels of geography that we have across Northamptonshire. It's within our gift to do so. So a real opportunity, particularly with the unitary transformation and the clear mandate from the phase 3 around developing integrated care partnerships across the sort of unitary and place footprints. So really, last point, Chair, is really to ask for the board's continued support around our programme approach. And so there's sort of 5 component parts of our programme and our development plan. A commitment from the board, but probably more specifically members outside of this board meeting, because I'm recognising the next meeting's probably in January, Chair, that we're going to need to do a lot of work together across the system around developing that ICS vision across the NHS, local authority and other partners, and how that integrated governance works. We still need to do that. So really looking for a commitment from members there, and just really to note the timescales that we're working to are tight. So February 2021 is our sort of system approval approach to becoming an ICS. Happy to take questions.
Okay, thank you, Tim. Very comprehensive and clear. So questions from colleagues for Tim? got a couple of hands. David Jones, yes. David.
Thank you, Nick, and thank you, Tim, for that encouraging report forward. One of the challenges for us is to improve on our engagement and involvement of service users, public generally, and so on. There are also challenges. I know there's a lot of discussion going on. Healthwatch is a statutory voice, and we're involved in a lot of those conversations, obviously, although not mentioned in the report specifically. Firstly is the offer, obviously, to say that we're always open to conversation and discussion. I'm having a meeting with Toby in October about some of those issues. But I think one of the real challenges for us as a region is to, as a county or whatever we're calling ourselves now, a series of authorities or whatever, is to really improve on that involvement of people. And it's going to be really important given the funding issues that are going to be facing everybody, a different sort of engagement, whether it's in social prescribing or whatever. And we're really keen to be involved in those conversations. And I think as a statutory body probably need to be referenced, Tim, I think in the paper. But to be frank, one of the frustrations of the COVID environment is that we cannot, those of us who are not part of your close-knit group, and Nick might be in a similar position, it's not so easy just to bump into people, to have conversations, to keep the conversation flowing. And I'm really conscious of that personally, and it's a real challenge. Thinking about how we can make that flow work, that sort of networking that goes beyond the immediate structure, but it actually involves people in a more open and transparent way, I think is a challenge for us. There's a responsibility on our end. Perhaps I should just be phoning people more. And I know there are the consultations that Tanji's leading and others, but I'm just flagging up that as an issue, as a risk, but also, frankly, in the context of a complete uncertainty about where Healthwatch is going in the new unitaries. We've got staff who are not certain where they're moving. We've got board members who are not certain. There are all sorts of uncertainties there. And we need to have those conversations flowing in an open way. So what am I doing? I'm flagging up Healthwatch's personal interest in this, obviously, but secondly, flagging up the issues about involving the public in a way that creates a different culture from what we've had before. And I think that's one of the criticisms of us as a county, frankly, and it's lots of positive movements. It's going really well, but we need to maintain that focus. Thank you, Nick. Thanks, Tim, for the report, and it's good to see progress.
Thanks, David.
Just to respond,
Tim, can I suggest you take Maria's comment and then respond to both? Is that okay? David, while you're on, I think what you've said does resonate, in particular with some of the conversations around the Health and Wellbeing Forum. So I think there might be a route in there. We'll discuss it under item 18. But Tim, if you can take Maria and then answer both, that would be great. Thank you. So Maria Wogan, please.
Hi, thank you. And I think David's point is really well made. I think it is difficult because the ICS work we're describing here is all dependent upon relationships, and I think it's very difficult for us to develop those kind of relationships and trust over these forums, and we're missing that informal conversations that help move things along. So that's sort of a challenge to all of us to find ways to make that work in the current way we have to work, because I doubt that's going to be changing. I think it's a really helpful paper, Tim, and thank you for that. The timescale you've set in there seems realistic as well. One of the things I think is interesting for this board is the relationship between this board and the partnership board. And I was just wondering if you've got anything more to say on how that relationship's going to work and how the two governance bits are going to fit together. Thanks.
Thank you, Maria. Tim.
Yeah, so just to, I guess, answer Maria's question on the governance, I think it's still to be determined, Maria's probably the straightforward answer. That's the gap in terms of, can we in clear words describe the closer stroke more formal collaboration? At this point, I don't think we can, and therefore we can't really wrap around the governance and how and the functions of the different boards and of how it's going to work if we can't describe that. So I think we need to start with that first, which we'll have a series of workshops during that time, and the ambition, Marie, is that we need to get to that answering your direct question. We should be able to clearly describe the role of the Health and Wellbeing Board versus the ICS Partnership Board, and at this moment in time I think we still need to work out how that's going to work. And then to David's point and Maria's shared view on engagement, I welcome the offer, David. It's something that the Partnership Board in September have sort of laid the challenge down, is how do we get that different offer of the network of networks, connecting with local people, particularly at this time where that sort of physical connection is obviously restricted, and so welcome a conversation or a series of conversations, David, in terms of how we can turn that offer into a proposal back to the Partnership Board. So I haven't got the answer, and what we can't do is, I guess, go back to ways and methods we've used in the past that we know haven't worked to the fullness of that sort of inclusivity across different communities. That's not to say that good engagement doesn't exist in the county. We know it does, but welcome the offer.
Yeah, thanks, Tim. David, your hand's still up. Is that the second question, or have you haven't loaded it from the last one? David Jones. Okay, hand lowered. Thank you. Well, thank you, Tim. So there are some. The board has been asked to do a couple of things on this. So it's to support the direction of travel for the ICS development programme, which, Tim, I think we do. Commit to the development of the ICS integrated governance and subcommittees. Yes. To note the ICS designation process and timescales. That's noted. Also, finally, Tim, note system working requirements as part of phase 3 COVID-19 response. Can you just briefly say what that is?
Yeah, so within the phase 3 letter, there was an ask around as a system that we need to clearly articulate our approach and arrangements for integrated care partnerships, provider collaboration, place-based leadership, and I guess the last point of my sort of presentation was we're still to determine some of that, and we need to do it collectively quite quickly together to hit the February timescale. So they're the requirements outlined within the letter.
Okay, thank you, Tim. Well, we can agree to all of those as a board. Thank you very much indeed. Item 8, Northamptonshire County Council update, Children's Services, Councillor Morris.
Thank you very much, Chair. Firstly, I want to apologise on Matt's behalf for not being here. Unfortunately, there's a clash with the Children's Social Care Improvement Board this morning, but he has updated me, and I will update you, and I will endeavour to answer any questions, though it may be that I have to pass them back. But in terms of what's happening, the Chair did allude to what's happened with the Chairman of the Children's Board. I won't dwell any further on that, except to say that the position is as it is now, and it was a Department of Education appointment in the first place, but I think we've got the right person in post now. So it was good that that the action was taken very quickly to rectify what could have been an issue going forward. But anyway, we'll park that. So everything is going very well for the go live date on the 1st of November. Still aiming for that. There's a Department of Education gateway review on the 6th of October to review the position. So it's looking pretty good for that. Obviously, the contract is a massive part of that, and it's very well advanced. Just out of interest, the payroll system has been run as a trial payroll run and has gone well. The staff are beginning to be TUPE'd across and is well underway. In terms of performance of the children's services, it's steady and good practice improvement across the board. It was interesting, we were expecting a surge of referrals when children went back to school as lockdown and restrictions were lifted. This oddly hasn't materialised and is the same up and down the country. So there needs to be an effort to identify any hidden harm that we're not aware of as a result of that so far. So I think that's something to watch out for. There's also been a significant rise in home education numbers, and we were quite high anyway, which is a little bit worrying. but it also matches the national trend in terms of higher home education. But that's something that I know has been quite important to people, to look at that area, and I think that's an area that we'll probably have to look at in greater detail. So just to update on finance in terms of children's, and obviously the and generally, it's very steady performance this year, which is what we needed to go into the trust. So if you look at this period compared to last year, we were showing a £7 million overspend in this service. That is now not the case. So we're going very strongly into the trust and setting it up in the right way with a good balance sheet, as it were. So we continue to work closely and well with the DFE, and we've been very well supported by them. We're expecting another Ofsted visit soon, but obviously this could change due to COVID restrictions. I think all in all, on reflection, quite remarkable where we are now as to where we were last year in this service, and actually in the council overall. So I think I'll leave it there, Chair, as a sort of overall update. And if there are any questions, I'm happy to try and take them or pass them back to Matt. Thank you, Chair.
Thank you, Ian. Very clear, comprehensive. Any questions for Councillor Morris? While I'm waiting for you to raise your hands, Ian, this homeschooling, is it, what's the percentage?
I don't know the figures off the top of my head, but there were about 2,000 something children being home educated, which I think that's correct. Somebody might correct me on that, but that's the sort of percentage we're talking about. So it's not an enormous number, but it's always been quite high in the county. And I'm sure that's something that the trusts are going to be looking at, as well as obviously education going forward. Unless anyone else has got any comment on that from the NCC team, I'm pretty sure that's the case. So it's something that we've always been aware of, and it's something that we need to be, well, the two new unitaries and the trust will probably have to be aware of going forward.
And I assume it's just unregulated.
There is some regulation around it. I mean, this is not my area of expertise, so I don't want to get into the rules and regulations, but I think it is regulated, but people can slip through the net. And I think that's the danger, isn't it? So you've got people who obviously home educate well, and you've got people who perhaps don't home educate well. And I think that's where you get the problem, is the people who fall through the system that aren't being educated well at home. So I think that's probably the emphasis that's needed going forward.
Yeah, thank you, Ian. But also good news on the financial situation. That's a significant improvement from last year. So congratulations to all the hard work that's gone into achieve that. Thank you. David Jones.
Just to comment on the question about what is regulated. The government has been extremely resistant to regulating home education for a long time. When I was chairing a safeguarding board, chairs of safeguarding boards were very concerned about this, but there was considerable resistance. It's a very strong lobby. And of course, some people educate well, but basically children who are home educated are hidden. There is no systematic way, there's no right of access as far as I understand it. And while some people provide excellent home education, it's of course very easy for people to hide their children. And we've had a case in the county where there was a real problem. So it is a significant area of risk, and it's right for Ian to raise that. Thank you for flagging that up. It's difficult to know under current legislation what to do actually to have access to those children just to see they're okay. But in the current circumstances, we know that parents are very worried about risk to their children, and in a way, perhaps it's understandable, but it's worrying. Thank you.
Yeah, thanks, David. I agree with that. Any other comments for Councillor Morris? If not, thank you, Councillor. We can move on to item 9, which is future Northants updates, and invite Ian Vincent to provide a verbal update. Ian. Hello, Ian. Ian Vincent. Well, I can see that he's on mute and his camera's switched off. Maybe he's gone for a coffee. What I suggest we do while we wait to re-establish contact with Ian, can we move on to item 10, which is the last of the updates. This is the BCF and the IBCF and the I Can work stream update. The author is down as Anna, but I think Sam Fitzgerald will take this item up. So Sam, can you move on to item 10, please? Thank you.
Hi, so it's Katie and Sam from Adult Social Care. So I will do the overview of the BCF performance and ICANN, and I don't know whether Joe Fawkes can join us today, but I will take you through that, and Sam will go through the forward plan for the BCF, if that's okay.
Yeah, thank you both.
I'm on the line, Katie.
Ah, there's Joe. There we are.
Yeah.
So I'll just go through the BCF report. So obviously, not surprisingly, given where we have been with the health system over the last few months, this is obviously, there are elements of this that have been suspended and indicators. Obviously, at the level 4 incident, the NHS didn't formally approve or require local systems to publish their BCF plan, and allocations have been made public locally. So Sam will talk through the element of what we're doing around the plan, the forward plan for this year. So I'll just take you through the key indicators. So obviously, first point was around reducing non-elective admissions to hospital. Not surprisingly, that was dramatically down in the first quarter, but that was not necessarily for anything other than people we perceive avoiding because of COVID. You know, people weren't necessarily going to A&E, and we know hospital attendances were down during that period. Detox, so that was suspended in March, the count, so I've put the data up until March. We haven't had any further guidance on what is happening with that, when that is due to restart. Reducing the rate of permanent admissions to residential care. So you may well be aware that we took a different decision in Northamptonshire, and we used a brokerage system. The CCG employed a brokerage system to discharge people from hospital. Because of the guidance around when those people need to transfer to adult social care. So that transfer only started in part at the beginning of September. Those numbers are down, but they are not reflective because that cohort still need to be transferred over to adult social care over the next few months. And we have a plan to do that. And the proportion of older people who are still at home 91 days after discharge from hospital. So that is a reduction. We're looking into why that is a reduction. We think there's a number of different factors in there. Some of that is COVID and people that were particularly poorly and may have unfortunately passed away, but also understanding what happened in that period of time around reablement and rehab services that may have had an impact on why that number has reduced. So that is effectively the report. It is obviously brief and summarised based on where we are in terms of national guidance around BCF. It may be helpful actually if Sam does the plan now, that makes sense, and then we'll come back to ICANN separately. But if there is any questions about that report, please let me know.
Okay, can we hold that, Katie, until we come back to we hear from Sam, and then we'll take it all together. Thank you. Sam, over to you. Thanks, Katie.
Okay, thank you. Okay, so as Katie's just said, this year has been like no other. So the Better Care Fund plan for 2021, the purpose of the report is to give the board an overview of how we plan to deliver on the BCF. The plan has been developed and agreed by NCC and the CCG. The report has been written in the absence of any national guidance, and therefore what we've proposed in the report is that we roll forward the existing schemes into this year until any further guidance comes out. We'll continue to use the Better Care Fund as a mechanism for personalised and integrated approach to health and social care, and to make sure that we get, we enable people to remain independent and at home, and that we enable people to return home to an independent after hospital stays. What you will hear later in the update that Katie is going to provide is we've got two major schemes that we'll be working on, and Tim's already alluded to some of these. So that's the ICS and the ICANN programme, which we'll go into a little bit more detail later on. The key metrics will continue to be the same, so the update that Katie's just provided. So we'll be looking at non-elective admissions, reductions in admissions to residential and nursing placements, the effectiveness of reablement and delayed transfers of care. And obviously when we get the guidance on those reporting, we'll provide quarterly updates back into the Health and Wellbeing Board as we have historically. The funding streams that are included within the report that I've attached as Appendix 1 are the BCF, so the Better Care Fund, the IBCF, the winter pressures grant, the disabled facilities grant, and any other additional funds that NCC or the CCG put into the pot. So what we're asking of board is that they note the BCF plans, schemes and expenditure as in Appendix 1, which is exactly the same as it was last year, that they agree to the planned metrics and trajectories set out in Appendix 1, and that the board approve the BCF plan for submission to NHS England.
Okay, thank you, Sam. Is Jo going to say anything about the ICANN program update at this point?
If you want me to.
Yeah, we can do that now.
Yeah, thank you.
Okay, morning everyone. I'm Jo Focus. I'm the Chief Operating Officer at Kettering General Hospital, and I'm one of the leads for the ICANN programme. In your pack, you've got a summary slide of the ICANN programme and the first edition of the comms that went out last week. So I'll just go through some high-level stuff, and then I'm happy to take any questions. And obviously, Katie is a big part of the programme as well, so I'm sure she's happy to take any questions as well. So I know you all know this, but obviously in 2019, a lot of work was done across Northamptonshire to identify the challenges in the system and the fact that in 4 years' time we would not be able to support our residents. The COVID crisis taught us, especially the acutes, working with system partners, that we could do things better, and we did. And we worked across our organisational boundaries for our patients, and we were successful in that time. But we recognise we still have a burning platform, so we've put together the ICANN programme, which is short for Integrated Care Across Northamptonshire. There were 3 aims to the programme: ensuring that we choose well, that no one is in hospital without a need to be there, ensuring people can stay well and can live well by staying at home. There are 4 pillars to the work, and the idea of the pillars is that a patient journey starts in the community and primary care and ends within the community and primary care. And you will see how that programme fits together in terms of work in the primary care and community, and stopping people getting into crisis is a key part of the programme. Supporting people that have got long-term conditions and ensuring they only go into hospital, for example, if they've got frailty, when they need to. And we need to ensure in the acutes that service is responsive. We get it right in terms of discharge, and we know in the past that we haven't as a system. And in terms of the NAS-TOM programme, which I'm sure you know all about, it's about improving independence for our patients and our residents across Northamptonshire by getting the solutions right for them, and it not always being a bedded solution. So to give you some background in the programme, we've been to the Health and Care Partnership Board 3 times now talking about the programme. We have support from the board. We have support from our regulators who have approved our business case to start the programme. And we're currently in what is called the assessment and diagnostic phase. And we're working with a company called Newton Europe, who Katie is working with for the NAS-TOM programme as well. Once we finish the assessment and diagnostic phase, we will then have a phase where we take another case back to our boards and we talk about what has been identified, what the opportunities are, and we will put together a business case for the next phase of the work if we decide to go forward with that work. And it will go out to open procurement. And then we would go into a further 12 to 18 months of designing and adopting and implementing quite a lot of change across our system. And it would be a massive change across our system. An example for you to note would be that a big thing about the programme will be moving resource around. So resource may go from the acutes into primary and community care to support our residents, our patients, and our carers to look after each other in the community and in primary care, rather than all the money being focused on the acutes. And my role in this is to make sure that as senior leaders, we focus on what's right for our patients, our carers, and our population. So I will stop there and then happy to take any questions.
Thank you, Jo. That's really comprehensive, and that sounds a really very innovative, very bold project, ICANN. If you're going to spread the love, spread the cash in the way that you've just described, well, that is seems like significant progress, perhaps something we should come back to more substantially later. But in the meantime, just to remind the board, we've got a statutory duty to scrutinise performance of both the Medicare Fund and the IBCF plans, and also perhaps comments on what we've just heard from Joe. So open up to board members, questions for Sam, for Katie and for Joe. Looks like people are happy so far. What I can do, I can scroll. I've got a couple of hands coming up. So Jonathan and then Maria. Jonathan.
Really just to say that this has been received very well in general practice, because I think originally there might have only been 3 pillars in it, and the 4th pillar, which is the community pillar, was added in afterwards. And that's very important. It's no good saying we want to not have people in hospital and look after them well if we don't do that in the community. And so better support for doing that is an important element. So very much welcome that. And there have been GPs who've been very engaged with it, feel very energised by being part of that project. So I'm keen to see that it would move forward in the way this is intended. And this will be an example, if it works, of a whole system approach, which is what we're trying to do. So very good, I would say.
Yeah, I'd echo that. Thank you, Jonathan. Maria, yes.
Yeah, I agree with what's just been said, and I'm interested to know from Joe if there's any early feedback from the assessment phase, both in terms of what you're learning, but also how we're working together as system partners on this.
Yes, we've done some early case reviews and they've thrown up some really interesting things. And in fact, Katie and I had quite a discussion yesterday at the ICANN steering group about some of the findings of patients who've come into hospital in crisis. And when we've looked at it, there are varying reasons for that, but sometimes practitioners don't know what services are out there to refer patients to support patients and their carers in the community. Patients have gone into the wrong solution and it hasn't met their needs. And Katie was discussing yesterday how that learning will then work across all the pillars. So actually we get those solutions right. And people going into bedded solutions when they don't need to, and then it actually impacting on them even more, because that, you know, can obviously affect mobility and mental health and all sorts of things. So those early sound bites that we're hearing sort of tell us what we kind of knew, but has given us the evidence now to start making those changes and to look at what we need in the community and within primary care to support patients. And the primary care and community pillar is one of the most important pillars for me, and getting that right. And Jonathan's right, you know, that's a really key pillar, and we have to get that right.
Okay, thank you, Joe.
Working together. Sorry, the other question was in terms of working together. I would say, Katie, I don't know what you think, but it massively improved over the last 6 months, and we're almost doing everything together now, which is a sea change. Sorry, Nick.
I would agree. We have a really different approach, and that's across health, social care, primary care. So everyone has equal representation on this programme in terms of how we're moving it forward, because it's really important. The engagement, which we're investing in and looking at, which is around that communication and engagement will be the key to this. And we've really recognised that early and put in the right relevant expertise to help us, because the system is vast. And if you don't have a pocket that's not engaged in the way that they feel they need to be, then this doesn't work.
Yeah, okay, thank you both. I've got 3 people. I've got Joanne Watts, David Jones and Richard Auger. So can we start with Joanne? Joanne Watt, please.
So obviously I'm working very closely with the team on the ICANN, and really just want to echo the comments about everybody working really well together. It has been fantastic. People have represented where they need to. They've cross-covered for each other. I just really wanted to mention one specific group who are really important within all of this, and that's people at the end of their lives. So obviously there are many people for whom re-ablement is absolutely the right approach. But for people ending their lives, that's an area that's really important, particularly with the community and primary care planning aspects, sharing across the system, and is something that will then come into the new PCN DES contract as well as we go into October as well. So that planning to avoid hospital admission, particularly in the last 24 hours of life, is a really important quality marker. And so that will be one of the other areas that we look at, because it is really important that we give people a good death. It is one of the things that is much easier in many ways to plan than a good birth. And I think it is something that as a system, we need to do our best. It is really difficult. And one of the areas that is very challenging is where families would have traditionally all moved in. And certainly as a Corby GP, I would find 10 or 12 people sitting in the living room around somebody who was at the end of their life. That is obviously with the rule of 6 not going to happen. And actually it is much more challenging for carers, particularly for people at the end of the life, but also for frailty as well. So it's really good timing to see the carers strategy alongside this, because carers are going to be absolutely key as we move forwards.
Thank you, Jo. David Jones.
Thank you. Conscious I end up speaking a lot, but we're not in some of the other discussions where some of you are discussing this all the time. So forgive that. Just making the point about the link with social prescribing and the overlap here, whilst welcoming these really very, very positive developments, and it's very encouraging. The sense of greater partnership is palpable, if you like, and that is a significant factor. But the challenge, as Jo and others were saying, is around seeing that partnership at the senior level is translated into on the ground. And I think it would be really interesting to hear, if Nick, at a future meeting, some stories, some individual cases, some example of how this is actually practically working, because it's great for having partnerships at the top, if you like. Or the evidence would suggest that everywhere there are pockets of good partnership working, but there's also difficult for organisations to change culture. And this is such a huge change of culture. It would be good to have a bit more evidence of that impact. But thank you very much for the progress. It does feel palpable.
Yeah, good point.
Sorry, just to add to that, obviously the NAS element, the NAS Tom pillar, is a bit further ahead because we started sooner, and we're starting to see, and I'm more than happy to come back with some case studies of where we've seen, we've got some videos to share from people that have used the services where we've worked much more collaboratively, including with social prescribers, certainly linked to PCNs, and then the new social prescribing service that's coming, but also community police, housing, that much more holistic approach to supporting people. So more than happy to share that if you would like those examples.
Thanks. The one thing that I forgot to say was that one of the issues in Northamptonshire, and I think across the East Midlands from what I understand, is that the public feels that the safest place to be, until recently, has been in hospital. And changing that culture, that it is actually safe and better for you not to be in hospital unless you really need it, and that there are reliable, good, positive services in the community is really important. So the engagement strategy with the public to help them feel that if they're panicking and worried, they don't have to say, please, can I go to hospital? That is one of the most important things. And if we can help with that in any way, I'm very open for conversations about that. Thank you, Nick.
Okay, thank you both. Thank you all. Can I bring in Richard at this point? Richard Auger.
Thank you, Nick. Yeah, and it's really quite encouraging to hear about the partnership working. But it's really, I hope that is translating into people with regard to their budgets and not working in silos. You tend to find in our system, in the NHS and social care, that everybody has a bit of money to work on their area. And when there appears to be a connection between two services, there's very little cooperation with regard to one service paying for something that would actually benefit for them in another service, if that makes any sense. So, although it may not be the remit of NHS to pay for instance, I don't know, a bed, but it actually benefits them because that person then doesn't come into care. So I'm wondering, is that culture changing? Are people more understanding that actually investing in and giving money to other services is actually helping them save money, and therefore making the system far more seamlessly, and not having these sort of ridiculous arguments as to, well, it's not our responsibility, we're not paying for it, that's not our remit. is that changing? Because that's what needs to change if we're ever going to make it totally integrated, and if we're ever going to really give the public services, the joined up services they need. And I'm wondering whether that is happening, Nick. I wonder if anyone can comment on that.
That's a good point. Well, thank you, Richard. But I did actually feel that I thought Jo Focus alluded to that in her ICANN update, that there is, perhaps the first time I've been on this board, heard that there's a willingness to share resources to do exactly what you've just said, maybe in a more strategic, preventative way, as opposed to hoarding it just for yourself. If that's not too crude a way to put it. So I'm quite excited by this ICANN project. I think others are as well. I don't want to necessarily prolong the discussion at this point in time now. I mean, just to get us back to what we need to do as a board, we're asked to note the Medicare Fund 2021, the Q1 performance update and the ICANN program updates. I think we've noted that. Thank you, Katie. Thank you, Sam, for the work that's going on there. But in order to progress this discussion, perhaps we can, if the board are in agreement, have more of an update on the ICANN project, the wider remit of that, with some case studies at the January 14th meeting of this board. I'd be quite keen to push for that. If that timing doesn't work, thank you, Jo, Sam. Would that work for you as well, and Katie?
Yeah, that's fine.
Yeah.
Brilliant. Fine. Okay. That's really good. Well, thank you there. Thank you for that. So, and also we've the update with Medicare Fund. Well done on all of that. Ian
Sorry,
Vincent,
Chair, could I just ask? Sorry, I do need to ask the board to approve the BCF plan for 2021 for submission to NHS England.
Is this item 11? Because we're still on 10, which is the update. I was going to bring you back in under the statutory items. I'm just want to make sure I'm still on the right agenda item.
We blended 9, 10 and 11 together.
Okay, right. So we've kind of strayed across them from updates into statutory items. Can you just hold on that, right? Because I'd quite like to I'll give you space to talk about explicitly under the statutory items when we've all signed that up, I'm sure. But let's just pause for a second. So I want to go back on the agenda to Ian Vincent, the future Northampton update, and then we'll go back to you, Sam, for the sign-off. Is that okay? Brilliant, thank you. Ian Vincent.
Yeah, sorry about that, Chairman.
Everyone.
Right. Good morning. I'm going to blame the IT. Everything went blank on me for a moment, except your voice, Nick, which was very frustrating. I mean, one of the fallouts from the local government reorganisation is that we're obviously moving our platforms from different operating systems, and that's going to be my excuse this morning. But actually, it's probably more about dodgy users than it is about IT. Okay, so on a serious note, a lot has happened since the last Health and Wellbeing Board in terms of the progress on this programme. We've made most of the senior appointments now, permanent senior appointments, so chief execs, north and west, so on and so forth, 151 officers, finance officers, monitoring officers, right down to transformation directors for each the north and west. So a significant amount of work just getting those people on board and in post. Chief execs starting in one case on the 1st of October, and the other case on the 1st of November. So quite a bit of work now around comms and engagement, because we really are moving now into the implementation phase of this programme. There is just a little over 6 months for this programme to run before we will be going live on the 1st of April, as I've mentioned in previous meetings. So comms and engagement, really important. But what I would just stress is that bringing our 5,000 workforce into the frame and making sure that they're comfortable with this, understand what's going on, and with COVID and all the home working that's going on, obviously the problems that have been highlighted this morning are happening within the programme too, and this face-to-face contact is becoming more and more difficult in terms of the normal meeting routines. So we've been involved with the trade unions, and again, we've shared the information that we've had as it's become available. But the real thrust of the work that's gone on in the last few months has been on the blueprint preparation. So we now have blueprints both in draft and in some detail for the operation of the 2 new unitaries. That has been rolled out in terms of impact on staff, and just basically sharing that information. And the programme obviously has right from the start been split into a number of key areas, and all of those key areas I'm very pleased to report are showing a green RAG status at this moment, so they're on track for delivery. And we've already heard about the improvement in NCC's finances, and that obviously flows into the unitary budget preparation cycle, which is starting next month. We've already started the basic stuff, but the real effort will start next month in setting two budgets for the two new unitaries. Implementation is seeing us now more and more dividing our efforts into North and West, because they're becoming entities in their own right, as opposed to it being just a single program across both. And the other, I think, interesting thing for me is that we didn't think we would get much of the disaggregation of county council services done before vesting day. There's been a truly incredible turnaround in that. We now have probably 80% of our services in the county council disaggregated between North and West. Now, that doesn't mean that they've been completely split, so that there's an absolute defined North and an absolute defined West staff cohort. But what it does mean is we've got things that can be taken to that level. We've got other things that will be hosted for perhaps a 12-month period by one authority and provide services to the other, and vice versa. But to have reached the point where disaggregation can boast a figure of 80%, I think is quite remarkable. Obviously, and this was reinforced at this week's shadow executive meeting in the West, the main the thrust of our efforts is still concentrated on COVID and the response to COVID, and that is having an impact on the programme in the sense that the more staff we need to engage in this programme, the more staff we're reaching the level where they're actually heavily engaged in COVID work. And so I'm not flagging that up as a real issue at the moment, but I think it could become an issue, particularly if the second wave actually hits us hard and we have to reinstate some of the things that we've been able to relax since lockdown has been eased. So there is just a slight word of warning there. But generally speaking, the programme is pretty much on track. Really pleased that we've now got the senior appointments sorted and approved by members. That does help moving forward, because obviously up to this point, we've been working in a theoretical world. We don't have our two new chief execs in place. We don't have our new finance officers in place. And therefore, everything we do had the potential of being overturned when this senior team came in. And now, of course, we've now got that senior team. It's in good time to get this across the line on the 1st of April. And I think progress has been absolutely brilliant, if I'm perfectly honest. Partners obviously are very important to us, and in amongst something like 800 deliverable individual project items, partners feature in an awful lot of them. So I'll stop there, Chairman, and pleased to take any questions.
Thank you, Ian. It's very positive. Any questions or comments, clarifications for Ian? Well, I'm looking to see if hands are coming up. What I will remind you of is that there is a chat function here, the Zoom chat group. There are a couple of comments on there. One of them is from Russell. Can somebody please tell me who the new chair of the CT is? Children's Trust, that is Claire Chamberlain. So please use that function as well if you wish. Ian, it looks like there are no immediate questions from you on that. Can I draw your attention to item 18 though on our agenda, the Future of the Health and Wellbeing Forum? Isn't it pretty well formed in April the 1st? I assume this group will split into two. That's an assumption, but what happens to the forum? That's the question that perhaps we can come back to on later on in the agenda. Thank you.
Nick, can I just comment on the Health and Wellbeing Board? I don't think there is our assumption throughout the whole of this reorganisation has been there will be two of everything. That's been the primary assumption. What I would say is I think there's still some more discussion to be had on the Health and Wellbeing Board, because one or two, there was a decision made by the West shadow executive this week on the adult safeguarding board. They decided there that they're going to keep one board. And similarly on the children's safeguarding board, they also decided that they were going to keep one board. So one board across West and North in both cases. That does still require the North to make the same resolution, because clearly if the North say, no, we want our own, then the West will have to revisit that. But at the moment, whilst the original starting point was 2 of everything, there's at least 2 examples I've just given you that are actually going to be kept it'll be kept for at least 12 months and then reviewed, but it will go on as a single board rather than 2 boards.
Okay, that's interesting. Thank you. Thank you, Ian, for that comment. Any other observations for Ian?
Nick, can I ask a question?
Please, yes, Russell, yes.
Hi, Ian. Can I just ask how partners like the voluntary sector are being involved in the move towards unitary sort of activities and services? And the only reason I ask is that prior to COVID, Vin was involved in a couple of the workstream programs, and since COVID, we've not been involved at all. And I was just wondering basically how that is playing out in reality.
Okay, good question. Actually, the reality is we have what we call a business as usual meeting, which is basically the 8 current county chief execs have thrown open the doors to our partners. In fact, there is one next week. I think it's on Wednesday, but certainly next week. And at that board, the same invites go out that have always been there, i.e. police, health, and colleagues outside of the, if I call it the local authority family, are invited. I think it's probably once a month, but nevertheless, it is a regular fixed appointment date. And we give a programme update at that meeting, and those external partners have the opportunity to ask more detailed questions. So that forum is still available. Whilst it's not meeting as it used to physically, it is meeting virtually. And I think there's been, attendance has been a little bit mixed since it went virtual, but the invitation is still very much there.
Thank you, Ian. Russell, does that help?
It does, thank you.
Okay, thank you very much. Ian, thank you for that update. That's helpful as ever. Back to the agenda then, folks. So items 11 to 15 are statutory items, which the board has to take and sign off. They're all reports. Hopefully we can move through them relatively speedily. But Sam, can we go back to 11, or on to 11, which is the BCF Plan 2021 sign-off that you mentioned earlier? There's a report here.
Yeah, so I've attached the report as Appendix 1, which I wasn't planning to go through in detail. I did talk this through, sorry, we probably muddled up the agenda by talking it all through at once. So in essence, what I need to do is I need to ask the board to note the plans, schemes and expenditures set out in Appendix 1 for the Better Care Fund for 2021, to note the agreed metrics and trajectories set out in the appendix, and then ask the board to approve the submission to NHSE. Now, what's happened with the Better Care Fund, and as Katie talked about, is that we were expecting some new national guidance that hasn't arrived with everything that's going with COVID and what have you. So the decision has been made between Northamptonshire County Council and the CCG that we will plan to roll forward the same schemes that we did last year, which are to enable better outcomes for individuals, to enable people to stay more independent at home, and to support individuals after a hospital stay to return to independence. And so Appendix 1 sets out how we will measure them. The plan would then be to make sure that we report back into the Health and Wellbeing Board on a quarterly basis our performance against those targets.
Okay, thank you, Sam. That's pretty clear. So the request then is for the board to endorse the BCF plan submission. Are we happy to do that? Joanne Watts?
I've just really got one question about those specific asks. So I'm happy with it generally. Note that the risks that are mentioned specifically, I'm sure there is a risk register with mitigations within that. I noticed particularly the access to primary care, which is particularly pertinent at the moment, which is a recognised risk, and would very much urge the Better Care Fund to make sure that there is engagement with whatever structures we have, and particularly now we have the ICS board. I think it's really important that we use that new structure as a system to mitigate that risk, but I think it is important to recognise that risk, particularly in light of unprecedented amounts of activity within primary care, particularly at the moment. It is incredibly busy out there, so I think it is a growing risk. I'm sure that the team are absolutely aware of that, but I think it's just about using our new structures to mitigate that.
Yeah, absolutely.
Thanks, Jo. Sam, you happy with that? That connection?
Yes, yeah, absolutely. I mean, the two key main work streams are the ones that we've already heard about. So the ICS and the ICAN programme, and all of the deliverables will be picked up through those work streams.
That's great. Thank you, Sam. Thank you, everybody. So, yeah, that's good. I think you can take that as approval from the board. Thank you, Sam. Another of the statutory duties is, sorry, is there someone coming in? No. Another of the duties that we've got is to review and promote the additions made to the JSNA. So I'd like to invite Claire Blackmore, this is item 12, to present the JSNA carer section.
Great, thank you, Chair. So I'll just talk you over the JSNA quickly. So can everyone hear me okay? Just give me a nod or something. Fantastic, lovely. So the definition of a carer is anyone who provides unpaid care for a family member, partner or friend. And JSNA stands for Joint Strategic Needs Assessment, and it's an in-depth needs assessment that gives you a detailed analysis of the subject area. It's delivered by a working group and in partnership across relevant organisations, and the working group for the carers JSNA included Public Health, Children's Services, Adult Social Care, Carers Association and the CCG. So the Carers JSNA was completed in August this year. It provides current data on the numbers of carers, who they are and where they are. We use data from a variety of sources, and when we didn't have up-to-date figures, we used projected figures as well. I'll come on to the key findings in a bit, but examples of what's included is things like type of care given, the amount of care given, proportion of carers by district, borough, how it breaks down into things like older carers, young carers, the health of the carers themselves, and also the financial support for carers and carers allowance. So engagement work that we undertook included focus groups and events. We had a focus group of 80 people at Northamptonshire Carers Association AGM. We put a general survey online, which garnered 349 responses. And we also had a consultation with working carers as well. So just as an overview, there's an estimated 75,000 carers in Northamptonshire. Approximately 2,000 of these are aged 15 or below, and nearly 20,000 are aged over 65. Of these 75,000 carers, only 12,860 were registered with Northamptonshire Carers in September 2019. In the online survey that we put out, 63% of those completing the survey were not registered as a carer with any of the main sources of support. So this is the Carers Association, their GPs, or with adult or children's services. So this is likely to lead to a large proportion of carers being unable to access support to lessen the impact of caring on their lives. And it also means their voice is absent when we're trying to do key consultations to shape services. Of those who receive support in our survey, satisfaction varied massively. And from the online survey, 60% of those people not known to services voiced a desire to be put in contact with support, but were unaware of the support available or where to go to find it. So this response from a brief online survey shows there's a sizable group of carers who are not particularly difficult to reach, but they still want to make contact with support services. Regarding employment and employed carers, the online survey showed only 38% of employers were seen as supportive of carers, and 20% of people in work had not formed their employer of their status as a carer. The levels of support for carers from employers was variable, and carers wanted more consistent policies and increased flexibility. So just some of the key findings from the JSNA that you'll find is that a third of carers report providing more than 100 hours of care per week. This is unpaid caring activities. The highest proportion of carers, including older carers, are found in Daventry district. Within young carers, so those aged less than 25, most are caring for a parent. And nearly 3/4 of carers are looking after someone aged 65 or above. And almost 1/4 of those are caring for someone aged more than 85 years old. 85% of the carers completing the survey reported being retired or not in paid work, and 17% of those stated they're not in employment due to their caring duties and responsibilities. Nearly 2/3 of carers in the survey were experiencing a long-term health condition of their own, and quite worryingly, they also reported feeling tired, having disturbed sleep and general feelings of stress. One thing that came out of the survey as well is that isolation is a concern for many carers, and over half of them reported not having enough social contact, and 15% reported feeling socially isolated. So with the number of carers in Northamptonshire increasing by over 5,500 between 2011 and 2018, and a projected additional 7,700 older carers aged over 65 in the county by 2035, there's a real need for a joined up and responsive carer strategy. And so other main recommendations I'll move on to now. Maximise identification and recognition of carers, including the impact of caring on health and well-being. If we can normalise this and carers needs to look after their own health, we can help prevent burnout of carers and unscheduled emergency respite care. So this includes recognition from employers, as well as introducing carer-friendly policies and increased flexibility. We want to make information and advice accessible for all carers and increase signposting for this, both between and within services. People in our survey reported wanting support, but not knowing what was available. Support and advice needs to be consistent. There should be greater awareness of support offered to allow for better signposting. This could require publicity or events to ensure people are cited on what services are offered, by whom, and who is eligible for the support. And our survey showed there was a particular demand for support, information and advice on respite, finance and benefits, and also further information on long-term conditions and learning disabilities. So people wanted the support to be easier to find and more responsive to their needs. And just to underline our main recommendation that we really want a joined up and responsive carer strategy across Northamptonshire. The final point, it's important to bear in mind that this work was not divided into carers from the different prospective unitary authorities. So there are many similarities across the two future authority areas. So the needs identified and the associated recommendations are pertinent for future services in both North Northamptonshire and West Northamptonshire. So to conclude, we're requesting the board to endorse the JSNA and to approve the recommendations that I've detailed, but we're happy to take any questions or comments that you've got at this time.
Right, thank you very much, Mary. So that was a recommendation, and the board asked to adopt the report, note the considerations of the findings, etc. Are we happy? Comments? Okay, thank you, everybody. It's a good report. A lot of work has gone into it, so thank you very much, Mary. And I'm sorry, apologies. I've had you down here as Claire Blackmore, but you're not.
No, that was Claire who was speaking.
We're a joint effort.
We're both here, so Claire did that report.
All right,
Thank you, Chair.
Thank you both. Okay, so you're happy with that then? That's good. Thank you, everybody. Another statutory report item that we have to consider is to do with the pharmaceutical needs assessment. We've got a statutory duty to oversee publication of this needs assessment for the county. It's due a refresh by the 31st of March 2021. So I'd like to invite Charlotte, is it Charlotte Goodson, to provide an update on the current development and the production of the PNA.
Nick, Charlotte hasn't joined yet, so shall we move on to David's Healthwatch report? I've sent her an email, but she hasn't responded.
Yeah, thank you, Cheryl. Okay, so David, over to the Healthwatch annual report, item 14.
Thank you very much. And you've been sent a link to the report, but I've got a brief report. We've only got a short time for this. So thank you very much. Just perhaps it's helpful to say to colleagues as we're moving into renegotiating the Healthwatch contract, which runs out next June. So it's a question of the new unitaries deciding whether they wish to do this together or not. At the moment, Healthwatch is commissioned through a community interest company, which is called Connected Together, that involves the university and Voluntary Impact Northamptonshire as a company, a community interest company, that then provides the Healthwatch service. And there are various ways of negotiating that contract going forward. But for such a small contract of only 200,000, there's an immensely complicated structure for us to work with. And that is one of the challenges. So moving on to the next slide, thanks, Cheryl. We see that the messages here are obviously about COVID, the impact of reorganisation, the county-wide clinical commissioning group, a helpful development, the Children's Trust, and the management for hospitals. All of these things are impacting Healthwatch, and we're, as I've said earlier, looking at how the views of the public can be fed into the planning processes through all of this change. And we're really pleased about the joint work that's going on. And Healthwatch basically has a small staff, one full-time and a number of part-time people, but it's mainly dependent on volunteers, as you see in the next slide. We have 52 volunteers. Our funding is 195,000. The next slide, Cheryl, please. Our funding is 195,000 for the whole county. That is supplemented by some small sums, CCG funds, Young Healthwatch, as I understand it, and there are some other commissioned projects. But basically, without labouring the point, we are one of the lowest funded health watches in the country. You see there some of the numbers. Obviously, over 10,000 people visited our website, our social media, and we published 11 reports. With more resources, we could be more engaged with the public, and that is something that, in a sense, is troubling me, how we reach out to the wider public, as we've been talking about all the changes that are going on. So as we go on to the next slide, we see reports and activities. We did a major study for adult social services, a user survey, which fed back in their work. We did enter and view visits to a number of local mental health services last year, including a visit to St Andrews, and we continue to be involved with their improvement programme, and also the Wellbeing cafes run by Mind. We've had monthly visits to Kettering General Hospital, what are called 15 steps, which is a structure for evaluating care on wards. And thanks to Kettering, who've been really positive partners in this. We're talking with Northampton General as well about doing some similar things. We've done some work with Young Healthwatch in Northampton General and looking to develop some of those arrangements. And we've done a number of specific consultations, and there's Young Healthwatch. So moving on to the next slide, our priorities for the current year were set a bit before COVID, but clearly engaging with the redevelopment of A&E and urgent care at Kettering and all the hospital rethinking, which is going on at the moment. And obviously it's good that we're involved with that with others. Our plan was to focus on dentistry. I know for myself, having a broken tooth earlier at the beginning of the COVID, that getting to see a dentist is a challenge, but I hope that my appointment in October will go ahead. There are issues around dentistry, social prescribing and all that goes with that. And the ICANN, we've got a meeting with Joe coming up next month and around social prescribing. And then there's the developments with primary care networks, the whole discharge from hospital process, which we've been talking about. But on the next slide, we see the impact of COVID, obviously, and our engagement with some of those. I'm so conscious of the pressures on all those of you working in these systems, the pressure to move on and get changes implemented, remote consultations and things. Or some of this is welcomed by the public, some of the public find it difficult. It's so easy with the pressures to charge on and not to listen to what the public is saying and how they're reacting. Whether that's from central government right the way through, there's a real challenge there of listening to people. And I think it's going to become more of a challenge as the next 6 months works out. So delayed diagnostics is a real issue for us. The next slide, it highlights our particular link with Carers' Voice, particularly interested in the last presentation. Really very, very significant lack of sense of support and engagement with so many carers in this county. And I think the underlying figures there are actually quite worrying. And knowing myself through personal contact, some of the people who've, for example, somebody who's been caring for her husband with very advanced dementia, basically lost almost all services for several months and was basically locked in her house with him. and coping with that. She did have some carer going in, but all the other respite, she literally was not able to leave his side for months. And that is going to leave a significant challenge for us. I know people are aware of that. Into the next slide, and I've nearly finished, there is the focus on Young Healthwatch. We've had a number of awards. We have one of the most active Young Healthwatches in the country. And you see young is there defined as 11 to 24. They've done some very innovative things during the COVID period, virtual visits, as well as maintaining their contact. Some of them go on to careers in health and social care. So it's really good career building for them, but also they're very active. We engage with young people around PHSE, personal health and social education in schools. Did a survey there, which was, we hope, helpful. And the next slide shows some of the achievements of young carers. You can see there some of the issues, helping designing new friends and family test cards for children, working with wards at KGH and at NGH, being involved nationally in discussions with children. And we've got our Investing in Children Membership Award coming up. And the next slide goes on to look at some of the other things, patient-led assessments at KGH. So finally, social media. This is the next slide, young carers social media, but the whole of Healthwatch, clearly it's a way of engaging with people. We have significant numbers of pickups through social media. The young people are very active on social media, Twitter and Instagram, and no doubt TikTok, and all of these ways of communicating with young people are important. So that is it. It was a bit of a race, but the report is there for you. I'm very happy to share this, or that we can probably share the longer presentation, which has a little more detail in. But on the final slide, ask if there are any questions, Nick. So thank you, and I hope that was informative. Clearly, it's a challenge with moving to the new structure. Will there be two? Will there be one? Will it be funded through a kick? There are some things that we need to start talking about now, I think. And I'm really keen to have those. I'm also interested in thinking about whether we should be, forgive my call, it will go off. Will there be ways of involving other partners in Healthwatch? There are so many different structures, but there may be other voluntary sector partners who would be interested to be involved. I think there's a challenge for us in bringing together the very different perspectives. Inevitably, there are 1,000 flowers among user voices, if you like, in the public, but finding a more effective way to bring those things together to help the decision makers feels to me to be one of the challenges which we can deal with as we move into a new contract for next year. I'm very happy to take questions now or later. Thank you very much.
Thank you, David. Very clear, coherence. I've got one hand up at least. Joanne Watts.
So first of all, I want to thank Healthwatch for all their hard work, really very much appreciated, and it's really important to capture the voice of the public. So very much thank you. I think one of the things we're all aware of is increasing levels of anxiety, not just from a clinical point of view, but from the point of view of people's interactions with each other. And I know one of the emerging issues that's becoming more and more of an issue is verbal abuse towards staff across the entire public sector. People are irritated, systems don't work properly, disappointed, there are all sorts of things going on. And really, it would be wonderful if people were kinder to each other across the whole system. So I think that is something I think we all need to keep an eye on moving forwards. It is something that worries me hugely, particularly with regard to retention of staff who are a little bit fragile across the whole health and care sector, having worked incredibly hard going into a second wave. I think something about how do we all interact with each other, how do we help people to understand how systems work, and most importantly, are kind to each other despite the circumstances, I think is something that is probably worth all of us thinking together as a system. It's certainly a significant issue within general practice. The abuse that receptionists receive is not acceptable. absolutely appreciate that the general public are anxious and are worried, and I think it's something that as a system we need to work together in order to support the public, to be kind with the professionals that they're dealing with.
That's very well put. Thank you. Voice from the front line, I guess, and it's totally unacceptable. Some of the behaviours in the public domain are not what we would expect to see, are they? Any other comments for David? David, it'd be good if you could maybe circulate. I think you've sent us the link, haven't you, to the full website, to the full report anyway. But do you have some slides that you could circulate?
Yes, perhaps, Cheryl, we could send the original slide set, which has just a little more detail on each of the projects. I cut them out because of time. If I could just say, and this might be contentious, but frankly, the hate crime issue and speaking kindly to people is an issue that the most senior members of government and political leaders need to take extremely seriously. Recent comments by the Home Secretary about the traveller community are totally unacceptable and exacerbate this sort of tension. And this is a public environment. I'm not asking for politicians to respond, but they need to hear that some of us are deeply concerned, and that has been a pattern over the recent months. All of our leaders have got to give a clear lead about how we talk to each other and how we do that with civility and with respect. And I say that having thought carefully about what I would say. It is really important. I've been hearing about the increase in hate crime in parts of Northampton and elsewhere. Let us not minimise how serious this is. It is affecting people's health and well-being, and it's about political leadership. And those of you who are in contact politically, I would ask you, please, to pass this through to the most senior members of government and of the opposition. That is where the leadership has to be. Thank you. And thanks for raising that, Joe. It's really a very, very important issue from the front line.
Yeah, thank you, Joe. Thank you, David. Wise words indeed. We'll watch this space, but anything that we can do to help promote that, the best possible behaviour at all levels of society, I think is something which the board absolutely would strive for and welcome. Thank you. I think we have Charlotte Goodson in the room.
Yes.
Charlotte, can we return to your report, please? This was pharmaceutical needs assessments, item 13. So, yes. Charlotte, over to you.
Good morning, everybody. Apologies, I wasn't quite ready for you when you were ready for me. So I have the delight of telling you all about the pharmaceutical needs assessments. So you may recall that it is a statutory duty on health and wellbeing boards to produce a pharmaceutical needs assessment looking at the health needs of their population and how they can be met by the provision of services by pharmacies and dispensing appliance contractors within usually 3-year lifetime of the P&A. So I worked with the public health team on the current P&A, which was published back in April 2018. And the regulations require health and wellbeing boards to update the P&A every 3 years, although there are circumstances where you may wish or need to do so sooner. So we would have been in the process of working towards publishing the next P&A by April of next year, but obviously COVID came along and has slightly distracted everybody from the day job. And representations were made to the Department of Health, particularly the pharmacy policy team, to see if the timescale for the publication of the next P&As could be relaxed. Eventually, we've got the regulations amended. So those amendments came in on the 14th of September, so that health and wellbeing boards will have an extra year to publish their next pharmaceutical needs assessments, although, of course, if they wanted to start the work sooner, then they could do. Now, the issue that arose, particularly for Northamptonshire, was the split into 2 new unitary authorities and the creation of as far as the regulations are concerned, 2 new health and wellbeing boards. And there was a bit of a gap in the regulations as to what happened when a new health and wellbeing board was created, either as a result of a split or a merger. So the amendments that were made to the regulations that have come into effect also make provision for where this situation arises. So basically, where a new a new Health and Wellbeing Board comes into being, they also will have until the 1st of April 2022 to publish their next P&A. So we have some breathing space for this piece of work, which if we have a second wave or focus is taken away from routine work, we do have some relaxation in the timeline to get the next P&As written. So I'll be working very closely with the public health team to produce 2 P&As, one for each of the 2 unitary authority areas. So work has started on this. We've established a steering group with all the key stakeholders invited to attend that. And I'm working closely with the NHS England team to ensure that we have all the data that we require. And they very kindly assisted in the circulation of contractor questionnaires. So to progress to date, we've had the initial steering group meeting. We've undertaken the contractor questionnaires with the pharmacies, dispensing appliance contractors and the dispensing practices. And we undertook a patient and public engagement questionnaire over the summer, recognising the limitations of doing it online and that would exclude certain patient groups who either cannot or don't wish to access the internet, or indeed who can't read English. So we had a discussion around how appropriate it was, what our alternatives were at the time, and obviously being quite limited on being able to do face-to-face meetings. So recognising that it wasn't really as inclusive an approach as we could take, it was then really pleasing to see we actually got more responses than we did when we did the engagement on the current P&A. So those sort of main pieces of engagement with contractors and patient and the public have taken place. And I've been meeting with various members of the public health team and other members of the council staff to gather all the information that is required in order for us to, for me to begin to draft the P&A. So potentially looking to go out to consultation. So the regulations require a formal 60-day consultation on a draft of the P&A. So the timeline that we have is obviously going to have to be very fluid. There is very little point in doing a formal consultation when everybody's attention is on other things. We want to make sure that they are robust and meaningful documents and that we haven't missed anything as we've gone through that process. So I would anticipate, in the light of changing circumstances, that we may need to shift and delay the consultation, but at least we've got plenty of time to hit that regulatory deadline for both the P&As, and in the meantime the existing P&A will continue. That's the one that NHS England will refer to when it's considering applications. So we're not leaving anybody in limbo. Applications can still come in, NHS England can still make their decisions, and that will work fine. So we are looking for consideration by the board as to whether you would be willing to delegate sign-off of the pre-consultation drafts of the P&As to that steering group, or whether you would rather the drafts come to yourselves for review and formal sign-off before we go out to that 60-day consultation. So I would welcome views and thoughts on that particular point. But if there are any questions that anyone has for me as regards to the P&As, what they're all about, and the work that's been done to date, then please feel free to ask me. Thank you.
Thank you, Charlotte, for that update. So just to be clear, then you're asking us to, I mean, your recommendation to the board is that we do delegate the sign-off of the pre-consultation drafts to the project group. That's your ask, is that right?
Yes, that will give us flexibility, because if we have to move things around quickly, we would be able to do that more easily if that steering group can sign off the pre-consultation drafts. Yes.
Yeah, thank you. So, but board members who want to find out more information, they could contact you directly or indirectly. Is there a way that they could see the pre-draft anyway without officially coming to this group?
Absolutely. I mean, if you would like an update, so that we send you when we've got that full draft prepared, absolutely, I can send that through. I can either do that as a standard item, or I can send it through and it can be circulated for interest, whichever you would all prefer.
Okay, that's great. Thank you, Charlotte. So, colleagues, that's the recommendation, and that we do delegate sign-off of the pre-consultation drafts to the project group. Are we all happy to proceed with that? I'm looking for hands. If anybody wants to.
If it helps, it's a several 100-page document.
No comment from me, but other colleagues may wish to say. I'm assuming that silence is in support. So thank you, Charlotte.
Lovely. Thank you very much.
That's sign off, but it would be helpful perhaps Cheryl could circulate a link to the document just so board members who are interested can have a look at the full 200+ pages.
It's a fascinating read.
I'm sure it is. Thank you. Thank you, Charlotte.
Thank you very much.
Can we move on? This is the last of the statutory items, is number 15, which is the North Hampshire Safeguarding Adults Board annual report. And I'd like to invite Tim Bishop to update us on that. Tim.
Thank you very much, Chair. Just to remind people that this annual report has already gone to full council, where it's been approved by Northamptonshire County Council, and it will also be going to the governing bodies or boards of stakeholder partners for their boards to review the document. Historically, the report has also come to the Health and Wellbeing Board, a bit of a belt and braces kind of exercise, if I'm honest, because it really has gone to partners already. I would assume that you've read the report. The only things that I'd like to highlight for you is that we've met our statutory obligations in terms of the number of times that we've met this year, that we've produced a strategic plan, that we've produced an annual report, and that we've also undertaken safeguarding adult reviews. You'll see within the document that during the time that this report covers, which was up until the 31st of March this year, that we did publish 2 safeguarding adult reviews and had practitioner events in respect of those, so that colleagues could learn from those reviews. We've also undertaken a multi-agency case audit on street homelessness and mental health, and that was something that the board was particularly concerned about in relation to street homelessness. And as part of that, we've also improved our links with the county's Chief Housing Officers Group, and in terms of the reporting and overview, particularly of street homeless deaths. We've also, I'm quite delighted to say, after a number of years chairing the board, to have got up and running a dedicated website that has far more information on it than has previously been the case, and is dedicated to the Safeguarding Adults Board. We've also finally got into the early part of the 21st century by having a Twitter account as well, even though Twitter is probably a very old-fashioned tool now when compared to TikTok and Instagram and all those other modern things. We've also been able to do a little bit of work in terms of our communications, and for those people who do use the Northamptonshire County Council website, you will now see this week there is a safeguarding piece on the right-hand side of the screen, which again I really welcome that we've managed to get some safeguarding communications out there. We've also, obviously, during this year been quite minded in terms of what happens from the 1st of April next year, and the board took the decision a couple of years ago to express our judgment that one Safeguarding Adults Board across the 2 unitary authorities was the most effective and efficient way to safeguard adults in Northamptonshire and within the 2 new unitaries. That continues to be the board's view, and my understanding is that that view has been endorsed by the chief officers involved as well. Ultimately, it will be for members of those 2 authorities to make the final decision, but that remains the board's view. I think the other thing to say is just to thank partners for the huge commitment that they do make to the board. Particularly, I'd like to mention the police, who have a number of their staff working quite substantially on the board. One of their, I think now chief, or one of their superintendents, I think he is now, chairs our delivery board, and that's been exceptionally helpful. And also, once again, the NHS, who have chaired a number of the subgroups and who have been very helpful in terms of the support to the board. That's really all I wanted to say. I don't want to take up too much of your time, but I'm happy to take any questions in particular with regard to the report itself.
Tim, I think we note the governance hoops that the report's already jumped through, so thank you for that. It really is just for information for the board here. We're asked to note the considerable progress made by the NSAB during the period 1920, so thank you all of you involved on the behalf of the board for that. Any points for clarification, comments for Tim? Okay, thank you, Tim. Report received, noted. Thank you very much, sir.
Thank you very much. Yep. Goodbye, everybody.
Goodbye. So we can move on now into the home straits, folks, and the strategic issues, item 16 down to 20. Item 16 is a COVID-19 update. That's feedback from the Health Protection Board and Oversight Engagement Board. It's a verbal update, and it's Mary Hall and Councillor Ian Morris.
Mary, if you start with the Health Protection Board, and then I'll come in on the oversight. Thank you, Mary.
Yeah, brilliant. Okay, so the Health Protection Board, just to give an update on the COVID situation in Northamptonshire then, is despite the national figures of new cases increasing quite considerably in Northamptonshire, we are seeing a decrease in our new cases and a decrease in the proportion of people who are being tested being positive, so that positivity rate. So Northampton and Corby have been on the government watch list as areas of concern for the last few weeks. Because of this decreasing numbers, this decreasing new cases and this decreasing positivity, it is highly likely, we have it on very good authority, that when the new lists are announced on Friday, both Corby and Northampton will be taken off of the watch lists and no longer considered areas of concern. So ordinarily, this would be really good news, but we are, I think it would be fair to say, a little bit cautious about whether these decreases are real decreases or not. So we are aware that, for example, there may well have been a lot more testing of people with non-COVID symptoms. So particularly with schools going back, there might be lots of children going to get tested with runny noses or worried well. And if we have lots of increased testing in people that actually we know don't have COVID, then that positivity rate is going to be lower. So we're doing some more investigation into that. It won't change that we come off the government watch list. And again, the caution around that is the messages that might go out, it's all okay in Northamptonshire, and we're really keen that we're not seen as being all okay in Northamptonshire. So we'll be going to do lots of comms about great, good work, carry on, don't get complacent. And we would say that for population, but also for us as system leaders as well, to make sure that message is really clear. The other bits just to note, I guess, is that the new app is being released today, or has been released and can be downloaded. If you downloaded it before, you'll need to re-download it, because you'll only be able to do it for Newham and Isle of Wight if you downloaded it before. And then from today, the QR code requirements come into place, and the new curfew from 10 o'clock. Other feedback from the Health Protection Board is ongoing work with schools and education settings. The university is now back, as you know, Nick, and I would agree, we've done a lot of work with the university about the planning and preparation, and it seems a really good, it seems really well prepared. So fingers crossed, nothing goes wrong like Glasgow. Yeah. And then just, I suppose, just one other, or a couple of other bits to flag. If we are off the area, the government watch list, we will have less testing facilities, because they tend to plough them into those areas of concern or areas of intervention. So we might lose a couple of mobile testing units across the county. Our testing levels are, although they've dipped this week, are still at a level similar to our August levels. We just had quite a peak about 3 weeks ago, so it looks like we've dipped a lot, but we haven't. We're still at quite high levels compared to August. Going forward, once we're off that watch list, we may have slightly less capacity, availability of testing units, but our capacity within the labs is good. And then the only other thing is lots of flu vaccination preparation going on. If you're eligible for a flu vac, or if you know people that are, please urge them to have their flu vaccination. It's really, really important. And then we've also been asked and have put in place preparations for a possible mass COVID vaccination when that vaccination is available. And it would be looking like we would be needing to vaccinate around 600,000 citizens, 600,000 vaccinations, sorry. It's about half of the Northamptonshire population. It's a 2 vaccination process. You have one, and then 28 days later you have another. The additional interest or issue around that is you can't have your COVID vaccination within 28 days of your flu vac. So it's putting increased pressure on getting that flu vac done now, quickly, in case that COVID vaccination does come online in the near future. I think that's everything, unless there's any questions on the COVID situation.
That's great. What a great, thank you, Mary. That's some interesting update, and encouraging that the rate has dropped. But as you say, it might cause unintended consequences with respect to testing later downstream. Quick one for me on the flu stuff. We had there's a lot of noise on the media lately about lack of flu jabs. Is that going to be an issue for us in Northamptonshire, even if it's true? I don't know if it's true.
We've only just started the flu vaccination programme, so I haven't heard anything locally, but I don't know. It would be a bit more fair to say, but we haven't had any issues or concerns raised locally at the moment, no. I think because the eligible population list has been expanded quite considerably, then is one of the reasons why the message at the moment is the vulnerable population first. So for example, it's been expanded to 50 to 64-year-olds.
Right.
Wait, guys, if you're 50 plus and you're not in that vulnerable population, let the vulnerable population go through first, who normally have a flu vac, and then the additional population cohorts afterwards.
Okay, thank you very much for that.
Okay.
I've got a couple of comments, hands up, Richard and then Jonathan. Richard Auger.
Thank you for that briefing. It sounds as if we haven't had the problems that have been reported in the national press with regard to people wanting tests and being sent to Scotland, quite a long way from Northamptonshire. Is that the true picture, that we've been, because we have had some additional assets and resources into Northamptonshire, that we haven't had those sort of problems?
I think, as far as I'm aware, there have been issues in terms of being able to get, so when people might go on, for example, at 3 o'clock in the afternoon to get a test, they haven't been able to book an appointment there and then, but they have been able to do, for example, in the evening when more tests become available. We haven't heard of issues of people being sent off to horrendous places away. That might change, as I said, once we're not on that watch list, that might change. And then again, we've done a lot of comms, and we will be doing a lot of comms to emphasise, please only going to get tested if you're symptomatic. And again, that might be what's driving our decreased positivity rates, is that people who don't have symptoms are getting tested. So we're pushing that. You've got to have one of these symptoms. If you've got one of the 3 symptoms, get tested. If you haven't, don't. Okay.
Thank you, Mary. Thank you. Thanks, Russell. Jonathan.
Yeah, thanks, Nick. So first of all, on the COVID front, I'm very aware that from primary care perspective in general practice, activity is ramping up, not only because COVID is getting worse, but also because normal work is supposed to be resumed. There is pressure to avoid hospital admissions, and therefore a lot of work is coming more out into the community. And you're still having to work in a COVID-related environment, in other words, distancing patients and operating securely for protecting the public and the staff, and that makes life difficult. The additional pressures are now with the flu campaign, and of course then potentially the COVID vaccinations in some future day. So there is quite a bit of pressure on primary care and general practice, and there are questions about whether to reset up hot hubs and the resourcing behind that, which are ongoing. On the flu front, the situation is difficult because the flu vaccines were ordered in the spring or even earlier, sort of almost this time last year. We're ordering for next year. Now that means that what was ordered was on the basis of what was thought to be the cohort to be vaccinated at that time, which doesn't include the expanded cohort. There's also confusion about who is going to vaccinate the 50 to 65-year-olds, 64-year-olds, because there is suggestions that won't be done through general practice, it'll be done by separate vaccination units, and where they'll get their vaccine from, again, is very unclear. So it's very much up in the air, this. I fully welcome the idea of expanding the vaccinations, because the more people you vaccinate, the better the protection for the whole population is. The idea of only focusing on certain groups actually is quite flawed, because you still allow the illness to travel through the community if not enough people are vaccinated. So it's a great idea, but you're right, there's problems with the supply, and I think that's still ongoing to some extent.
Okay, thank you. Good comments, Jonathan. Mary, do you have any thoughts on either of those comments?
Yeah, I mean, if it's useful, Anna, our health protection lead, has been working on all the flu vaccination plans, so I can, rather than going into all the detail here, if I can connect you with her, Jonathan, if you're not already, and then some of that detail will be in the plans that she's got. Would that be useful?
Well, yes, I think it was more for comment for the whole group, but yeah, I think the more we know, the better. And Adam Nawaz has been the lead for general practice on flu vaccinations, extremely well informed, and has been involved in the talks as well. So he's keeping a very close ear to the ground and liaising, I hope, closely with you on that. And that's all to the good. I think we are working together on it. I don't think there's a split there at all.
So perhaps we can give an update at the next board, if that would be useful, or keep that update going on. So we're keeping everybody up to date with how it is going and what is happening, if there are any issues.
Okay, that sounds good. Thank you, Mary. Thank you, Ian, Jonathan. Can we bring in Councillor Morris now? Mary, are you happy to hand over to your colleague?
Yeah, absolutely. Yeah, thank you.
Thank you, Mary. Good job.
Thank you, Mary, for that very useful update as always. I'm not going to say too much, because the Oversight and Engagement Board, quite a few people who are on the line here today do attend that. It has been a very useful forum, I think, particularly the private section of the meeting, where we are presented with very high level data, which is very useful, I think, for the councillors particularly, but also everyone who attends, because it helps them to understand the situation as it actually is. And also, it's worth pointing out that it's cross-party, it's across all organisations. There's an awful lot of people who attend the meetings that are worthwhile, and I think everyone is much better informed as a result of them. They happen once a week at the moment. Normally they would happen on a Thursday, but we've moved them to a Friday, so there's one tomorrow if anyone wants to tune in. It's always obviously the private session isn't possible, but the public session is. But they're very useful information forums. And I think Lucy, particularly, I'd like to give Lucy Whiteman a shout out, because she does an amazing job with the information that she supplies at that meeting, and actually at the press conference on a Friday as well. It's a sort of dual act for the Oversight and Engagement Board with the press conference on a Friday, which I think does really help inform everyone in the parties and the press as to what is going on in the county, and I think it's been very useful. Anecdotally, talking of flu vaccinations, I do know that my neighbour who was shielded has already had his vaccination for the flu, and the local practice is already rolling them out amongst the shielded population in the local community. So that is already starting, and people are obviously starting to get their appointments for later dates. So I don't really want to dwell on the Oversight and Engagement Board, because I think Mary's sort of filled in a lot of the information, but it is, I think, a very worthwhile board, and it does help to, as I say, engage with the public and with the members, I think, most importantly, and other professionals across the piece. So I'll leave it there, Nick, but I'm happy to take any questions on that.
Thank you, Ian. Questions? I've got actually Jonathan Ireland's hands up. Maybe that's a legacy hand, but David Jones's hand is up. David, can I bring you in first?
Yes, just quickly. I am on the board, supposed to be representing the public voice. As always, it's an issue of how you know what the public voice is, but we try and keep close to the ground alongside councillors. I just wanted to say two thank yous. One, I endorse what Ian has said about Lucy and the public health team and all of those who've been involved. It has been impressive. People are on top of the issue. They know the trends. I know there's a lot of background work goes in around testing and all the different elements. It's been a real example of partnership working, and from the public's point of view, I think we need to recognise that. I'd like to minute it formally. Because it's been a huge effort and at personal cost to people, but it has served the public well, I think, and the news today is encouraging. And I'd also like to thank Ian for the collegiate way in which he chairs that meeting involving people across the parties and other stakeholders. It's been a really constructive forum and one that I found really helpful, and that's down significantly to the chairing. So thanks to the chair as well, Ian.
Yeah, I think the board echoes that, in particular, the work that Lucy and her team have done, not to take away from other people, but she's done a great job on behalf of the county.
Can I just give a shout out, Nick, for the comms team as well, while we're so I neglected to mention them, and they have worked very, very hard throughout this whole crisis on many, many levels, and we get updates constantly on what they are doing. And really, a lot of it is down to the messaging that they have pushed out across the county. We wouldn't have the levels of testing we've had. We wouldn't have the levels of compliance, many other issues if it hadn't been for the comms team. So we really need to recognise them as well. And if I can give a shout out as well for, they are currently doing a survey, which I'd like to just give a little heads up for, which is a COVID-19 testing survey, which would be great if everyone could get on and do. We've had a lot of people reply to it already. Quite a staggering number of people have gone on, but I'm just going to read out the link. It's northamptonshire.citizenspace.com/public health/. So if everyone from the board could go on there and have a look at that and fill it out. It takes about 10 minutes, and there's going to be some really interesting data coming back from that. It's particularly keenly focused on people who don't feel they want to adhere to the rules, but I'm guessing that they probably won't be the people who answer the survey. But let's see, you never know. We'll see what the intelligence brings out. So sorry, Chair, I forgot to mention that, but I thought I better give that a quick mention. Thank you, Chair.
Ian and Nick, if I could just mention as well, there is a Zoom consultation with 18 to I think it's 29-year-olds. And this is a really important group, and there's a wish to engage with that group to hear their response, their experience, their views. It's easy to stigmatise groups or to be critical of people for not following guidance, but actually finding ways of encouraging people to think it's not only about me, but it's about all of us, and helping people to see that is really good. So that meeting is really important, Ian, I think.
Yeah, thank you both. And Ian, what we'll do, we'll ask Cheryl to circulate that link to the survey to the members of the board subsequently. Thank you. So thank you, Ian. Thank you, Mary. Can we move on then to item 17, which is approved mental health professional provision within Northamptonshire? Just a slight bit of background to this. Had been some or concern has been raised at the board's mental health crisis concordant subgroup about the provision of AMPHs within the county and the impact this has or may have had in delivering high quality healthcare to patients. So I'd like to invite Adam Smith, the Assistant Director of Crisis Pathways, to tell us about the issue. Thank you.
Morning all. Thank you, Chair. I'm here. Sarah Jenkins and Sam Fitzgerald and Jane Bowen are present as well, so they'll pick up on anything that I miss, which is highly likely. The issue is, as you've said, I chair the current Crisis Concordat meeting for the county for mental health. So I raised this issue to you in that role, but also as an issue that's been raised by our acute care colleagues in our general hospitals and locally by police and ambulance colleagues as well. Just as a very brief understanding, we're talking about approved mental health professionals within the county. These are local authority posts, or they act on behalf of the local authority to oversee mental health assessments, under the Mental Health Act for some of our most vulnerable mental health service users. So these are people who are in crisis, who are seen to be deteriorating and who require urgent assistance to either get mental health support or admission into hospital. So it's a vital function for the county. Whilst it is the responsibility of the local authority to coordinate that function and to some extent provide those, it is a system need. So systems who have mental health professionals can put forward people to train for these posts. But the significance of the issue that we have in the county is that we've for some years been running on a incredibly stretched service. The recommendations for the numbers for our area should be that we have 63 whole-time equivalent approved mental health professionals. We have 27 in the county and they are not whole-time equivalents. They work, we have some whole-time equivalents, but predominantly these are people who work into other areas and then rotate onto our AMP rota. So that means we have very low numbers of AMPs during the day, and at night we have we go down to 1 AMP provision in the county, and you'll see that within the report. And you'll see within the report that there are the numbers and the timings around that. And this is an issue that's been raised at the safeguarding boards by myself from the Concordat. It's an issue that we've written this paper for to bring to yourselves, and we've taken internally within our own organisations. But we're at an impasse both, and I know you don't have access to funding, but we're with an impasse as to how to push this further. But we do see this as a significant area of concern without action. Northamptonshire Healthcare Foundation Trust have put forward 3 mental health practitioners this year for training, but there is still a need to A, resource and B, find the funding for a greater level of AMP provision. The impact is that the people that require mental health act assessments are sat often within the community with family or carers awaiting those assessments, sometimes for 24, 48 hours or more if over a weekend or if in a particular challenge time. So it's a significant concern, and we would welcome support from the board and suggestion of how we might take this further forward.
Okay, thanks, Adam. So there's the request and there's the ask then to the board to give consideration to, I guess, a system-wide approach to this. I'm not sure we can do much about resources as a board, but we could certainly help to make the argument if board members feel that there is an issue here, which it seems that there is. Richard Auger.
Yeah, I think this goes to the point I was raising earlier, whereby, if we don't do anything, then it's going to impact on other areas of the system. And look, we're all here, we're all representing various individuals, so why not, do something positive. I know it's not our responsibility, resources, but the people are here that can do something about it. So Adam, I challenge you to invite the personalities here that do have budgets and come together, and let's make this sort of partnership, this real partnership. Everyone's saying let's go and let's make it work by getting you financial resources, because if we don't get you financial resources, we're all going to suffer, because the situation is going to escalate and we're going to either end up with dealing with people hospitalised, self-harm, suicide, and therefore we all lose. So, I don't know why we're not doing this. If we do want to work in partnership, it means we need to get together, share resources, share budgets to get the assets out there that are going to prevent tragedies and prevent further costs down the line. It's just common sense. Thank you.
Thank you. Maria, and then Jonathan Ireland. Maria.
Yeah, I totally agree with what Richard said, and this paper does make the point he raised earlier that this is a system-wide issue. Responsibility for funding it may sit in certain organisations, but the impact is felt across the system, and in our population with some of the most vulnerable people just aren't getting the support that they need from us at a time of crisis, and the impact that must be happening on those individuals and those families is significant. And I think as a Health and Wellbeing Board, we have a responsibility to make sure that something happens in response to this paper, which I think is really helpful in setting out what the challenges are. It's obviously quite a complex system issue, but I think the way it's been written is very clear in terms of what we need to do. There's recommendations towards the end of the paper that I think as a board, we should be saying to partners who are around the table, you know, how are you going to respond to those recommendations, and expecting feedback on that at our next meeting, so that we're supporting the Crisis Concordat, who've quite rightly raised this issue, and showing that we're listening and that we're going to do something about it. So I would really support the board taking some steps here to show we've heard what the problem is, and we're asking partners around the table to respond positively, recognising that if we all pull together on this one, we probably can make a significant difference for our community. So that's my view, and I really think it would be helpful to get that agreed today if possible.
Okay, thanks, Maria, well said. Jonathan Ireland, got Sam Fitzgerald and Joanne Watts. Jonathan.
Yeah, thank you. Obviously very important this is. I did find the paper quite difficult to read. The wording is quite complicated, I found, and even though I kind of understand it, I think one thing, my understanding would be that these workers are essential for where a patient has entered themselves or others, which is essentially when you're going to do a mental health assessment and admit them under section, or whatever the latest jargon is. Now, that obviously is extremely important. It's a legal requirement as much as a social and medical one, but to safeguard the patient and the community, essentially. Now, moving on from that, if I've got that correctly, the issue would be the level of need that's out there. Because what I didn't get from the paper is how many sections are performed every week or month, and therefore the number of staff that are required to do that. Now, of course, you can never use, like fire engines, you don't know how many fires it's going to be, but at the same time, so clearly you could get 5 sections in a night. But the issue to my mind was, yes, I understand that there clearly is a need. You must have enough people on the ground that are accessible, but I'm not quite sure what the level of workload was, and I'd be quite interested to know that.
Okay, they're good points. We'll come back to that, and I've made a note of that.
Can I just mention very quickly, Chair, that the numbers are within the document. So on page 3, we've included 3 months of data from the start of the year.
Well, apologies, then I missed that. I do apologise.
Okay, thanks. So the numbers are there. Thank you for that clarification. Sam Fitzgerald.
Hi, thank you. Thank you, Adam. That's really helpful. I suppose if we're looking at the wider solution, it might be helpful just to reiterate really that this isn't just around a financial resourcing issue. So the approved mental health practitioner training currently takes about 2 years. So in Northamptonshire, we've struggled to retain AMPs. So we've lost either through retirement or through people moving on with progression. So actually some of that is around, is there something cross-organisation that we can do to develop an apprenticeship or a training programme that would enable us to develop our own resource to build some sustainability into our system? And the process in itself, which I know that Jonathan alluded to, isn't just in relation to the social worker who holds that qualification, but it's the availability of doctors, it's the appropriateness of the calls. And Adam, myself and Jane and Sarah will be looking at some solutions, particularly like we talked around it transformation-wise. Is there things that we can do together to deliver a better service, to get better outcomes for people? But it's quite a complex issue.
Yeah, appreciate that. Thank you. Jo.
I think the other thing is to say it's very much needs to be seen as part of the whole mental health work, very much part of phase 3 letter, something that we're all working together as a system. All of it is important from the point of view of what we're doing, but we also have the advantage of having county-wide workforce groups as well. So that's helpful as well. And so I think this is a profession that I suspect the general public and those increasing people who are interested in health and care know very little about. So I think it's very much about us looking as a system. You know, even as a health professional, I think I know what these roles do, but I probably don't know the detail. And these are people that we need to work alongside. So I think as a system-wide workforce group, we are going to have quite a lot of the population is going to have a bit of a rethink about what they're going to do. Obviously, people are not going to come from being members of the public to becoming approved social workers. But what we're going to look at is obviously as those people move into these more senior roles, there will need to be new social workers. People may well have a rethink about what they do. So I think this is our opportunity where people are exiting furlough to have a complete rethink about what can they do, and actually are jobs within the health and care sector something that they're interested in, which may support us in this area as well.
Thank you, Jo. Maria Wogan, did you want to come back in on the discussion?
Yeah, please, Nick. It was just, thanks, Nick. It was on the workforce point that people have raised. I really support that idea of thinking of different ways of delivering this, and not necessarily social workers doing the qualification and widening out the base of the workforce, and just wonder if this is something that needs to be picked up in the systems people plan as an area for action.
Okay, that's a good point. Thank you. I still see Sam and Jonathan Ireland's hands up. Sam, did you want to come back?
Sorry,
Okay.
it's Jane Bowen here. I appreciate everybody's efforts to want to support the training and to make sure we have greater resources and numbers. It is specific though. What we have to stress is that it isn't just something that people can train to be an AMP. It requires that people are already a social worker with 2 years experience, or a registered mental health nurse, or an OT, or a psychologist. So in a way, the entry requirement to start this training isn't a baseline experience. You have to have some experience elsewhere and a professional qualification. So the pool is quite limited in some ways to be able to do this. And I guess that's against the backdrop of a national shortage of AMPs and an ageing workforce. And I speak as one of the ageing workforce, so I can say that with quite clear conscience.
Yeah, thank you. It's looking to draw this one to a close now. It's clearly a very important issue. I think the board would want to, in principle, at least support the recommendations that are in the document, but bearing in mind that we don't have as a board instant recourse to funding, or also career development and progression. These are big, complicated issues. My thought is how would this integrate more broadly into cross-county initiatives, things like the ICANN program, for example? Is something that it could be picked up through that? So, I mean, I'm looking at Sam or others to maybe guide me in this.
The ICANN programme itself is really broad. What we do want to do is part of our unitary transformation. So obviously our AMP service will be included in that. And our transformation work certainly within adults, and then working with our partner organisations, is we do need to rapidly pick up this piece of work within that work stream. Right. What might be helpful if the board accepts is if we bring back an update in January to let you know how those conversations, as well as embedding sort of, the community hubs and those things, are progressing. And whether I'm also going to join the be the workforce lead for adult social care. So I'm more than happy to join any of the forums that are going on, and will be at the workforce board moving forward.
Yeah, I think that does sound a good idea to me anyway. I mean, it is clearly it's a county-wide, it's system-wide response required, not just sort of local interventions that produce a kind of patchwork which is perhaps not so well coordinated. Adam, do you take any comfort in what you've heard?
Well, I'm very pleased that people see the significance of the concerns, and I find Maria's points around actually maybe the Health and Wellbeing Board approaching partners to make some representation and ask directly for what their actions will be around this. Certainly, I think I've reached an impasse in my role as chair of the Crisis Concordat. I've attempted to make that representation, and I think it probably needs that next step of push, really, for me.
Okay, thank you. So if we give it some offline consideration and come back in January, hopefully with some more fresh ideas about how this could be integrated into other programs across the county, you think that could be a way forward?
Okay, that's yep, that's fine. Thank you.
Right, thank you. Thanks, Adam, and thanks, colleagues. We can we'll move on. Item 18 is the future health and wellbeing forums. So I have the pleasure in chairing the forums, and most recently concerns were raised. There are 7 of them, by the way, reflecting the current political makeup of the county. Concerns raised around the uncertainty and lack of clarity really about what will happen to these forums as we move towards a unitary status. They've received a small amount of money through what's called the Local Healthy Places Fund, provided by Public Health, Northamptonshire. So that has helped to catalyse some of these groups, but I think they still need our help and support. They're variably well attended, but they do provide a lot of the infrastructure and public voice that we've heard about throughout this entire meeting this morning. So comments from David on Healthwatch, Russell and others about community engagement from Katie, etc. Also work around what we can do to encourage carers and support carers as well. So they do, I think, have a really vigorous role to play, but they've not really reached their full potential. That's my feeling anyway. So what they decided to do was to put a paper together that's in front of you and a number of options, and just to distill it down really without prolonging discussion too much. What they want to do is, from the 1st of April 2021, is to keep the forums as they are presently, not to replicate significantly the unitary structure until that has, if you like, settled down. Post-unitary, they want to see if they could align themselves, so go from 7 down to 4 forums linked to the primary care localities. That was their wish. I want to sense check it with the board and find out, well, 2 things really: whether you feel that these forums are worthy of continued support on behalf of the board, and if so, would we accept the recommendation? So that's endorse the keeping of the existing forum structure as is until the creation of unitaries, then with some pause after that, the intention to reduce from 7 to 4 local forums aligned to primary care localities. Over to you.
Nick, it's Mary here. Sorry, I didn't put my hand up there, but just to say, the money that Public Health has provided to support the forum was just a one-off. So we're not going to be able to, unfortunately, do that going forward. So the statutory role of there need to be Health and Wellbeing Board, obviously we've talked about, sits with the local authority, and we don't know yet how that will be with the 2 unitaries. So in terms of support for that, you mentioned support, we would probably need to clarify what that support is, because there wouldn't be funding within Public Health to financially support, although there would be in terms of advice and support around the population health and information on health and wellbeing, for example. But it's just to be clear from the start that any support, if there are financial requirements, it might have implications for any decisions that are made.
Yeah, Mary, I totally get that, and I think that the forums do realise that that funding was a one-off. But the problem is it's sort of set a bar, and there's expectations now that they might even get administration support and all the rest of it, which clearly would be very, very difficult to do.
Well, certainly we would, and I think there's probably something about managing those expectations, isn't there? And I'm trying not to be making it sound like it's been really negative, but certainly it wouldn't be able to, there isn't any facility within Public Health to even provide the administrative support. So that might be something that would need to be discussed with each of the 2 unitaries, and how they'd want to do it, or with the, if they were in those 4 clusters, is how that might come from the primary care networks, for example. But we would absolutely want to support in terms of information and knowledge about the local population and that health and wellbeing of the local population. Yeah,
it's just whether my sort of feeling is whether we've got this sort of ready-made group that is bluntly of variable quality. They meet there. Sometimes attendance is very poor, and yet we have an urgent need to engage more widely. So we do have this governance structure in place. It's whether we how does it negotiate the unitary politics that's coming down the road to us. So that's the kind of question that they're asking. Richard Auger, and then Joe Watt. Richard, you're on mute still.
I think Richard's not there at the moment. Oh, here he comes.
Is he here? Hello, Richard.
I am sorry, I've got an electrician and trying to do two things at once. Yeah, it may have been said while I was absent, I was part of the Daventry Forum prior to being promoted as leader. And, you know, I think their work is vital. It really gives that, you know, closeness of partnership working. And I think the Daventry one particularly works well. So I think it's important that we keep that closeness to what's happening on the ground. We seem to be very strategic here, which is great, and we need that coordination. But I think that arm of the forums seems to be a really, really good combination of actually getting some of the work done. A lot of good work was done actually at that level, and I would encourage, we need to keep it going. Where it's funded, well, you know, it's not about one-off payments now, is it? We can't just say, well, it's a one-off payment. If we're going to be in this together, and we know it's contributing to the benefit of the public, and it's actually saving us money in the long run, we've just got to allow our budgets to pay for it. And so, so I would suggest that we keep them going, and one of the agencies or some of the agencies find the money to pay for it. It's not about managing expectations; it's about keeping them going.
Yeah. Okay. Thank you for that, Joe.
So just really wanted to add my support for the hard work that the Health and Wellbeing Forum are undertaking. I think they do a lot of important work. They very much link the voluntary sector in, and it is exciting, the idea of them working along the locality footprint as well. There is a slight error in the paper in that it implies that localities are the same things as federations. They don't have the same geographical footprint. So I really just wanted to point out to people that federations are not contiguous, I think is the word that we're currently using. But as I say, I think looking at those areas does bring some advantages when you look at the compromise with scale being close to the population, but also large enough to make a difference. And certainly if you look at areas like Kettering and Corby, many of the organisations work in both patches. So there is a logic to that. What I would urge us to do is to make sure that we have equity of support, both before and after the unitaries. Very aware that there is an anomaly, obviously, within Corby. I think it is important for us as a system to work out what the administration and support is for those. But I think we probably need to have that conversation prior to unitaries, because if we expect these organisations and these fora to continue before then, that system of equity of support is really important, and it is very inequitous at the moment. We have enough inequality within our county. That is something that as a system we need to be working on at this point to ensure that the hard work can continue.
Yeah, thank you, Joe. That's good support actually. I mean, I think they do have value, but they're an underutilized resource, and two issues about managing expectations, and also the quality and level of input that we receive from the seven at the moment is variable, but could be better. Can I take it that that we're all happy that these the wellbeing forums should continue, irrespective of what happens with the unitary, that they do add value into the community in the way that we've discussed previously? Well, that being the case, then, if we from the 1st of April, if we keep the forums as they are presently, and when the unitary takes place from the 1st of April, what would it look like if the seven broke down into four? So there might be some mergers for instance, North Wellingborough and East North Hants, but that merged structure aligned to the primary care localities. So I'm looking at perhaps Joe again. Would that work?
Yeah, so I think that would be a very effective way to work, because when you're looking at primary care networks, the NHSEI aspiration is very much that extends way beyond the allegiances between the practices and into community pharmacy, local organisations, social prescribing. There would be a huge amount of logic to looking at those, and actually we have the advantage that our primary care networks don't cross those boundaries. we've been incredibly fortunate with the way that our practices have formed themselves spontaneously, in that actually you would have neat areas. It does divide itself very, very nicely, and would give that much broader community field. So that from my point of view, and from knowing what we know about the localities, there is an entire geographic logic, but also there will be times where they need to come together to share ideas and experiences, and feed up to health and wellbeing boards, and that's also really important.
Okay, that's very helpful. Thank you, Jo, for that. We've got David Jones and then Tim. David.
Thank you. My colleague Simon Barter, one of the Healthwatch volunteers, has been involved in doing the background work for this project, and we're supporting, I think, the idea of aligning in this structure of 4 in the future for all the reasons that Jo said. It makes sense. It's important that we try to work to make the boundaries make sense. We have this opportunity to do it now, but if it fits well in that way, and obviously Healthwatch is involved in all of these fora with a number of different volunteers. There are options about how we structure things, and one option could be that, and this is from a Healthwatch perspective, but we could provide some minimal support. There would need to be some infrastructure to make that work, but providing support to the fora through Healthwatch could provide some consistency and some energy, if you like. If people felt that was helpful. It couldn't be done on existing resources, but that is an option, which one of many that we could be exploring over the next few months with the new unitaries as well as the CCG.
Yeah, it's very helpful. Thank you, David. Tim.
Thanks, Chair. Just a practical note. Tanchi Harper and Dion May, who have been tasked from the LHCP board to look at exploring sort of patient and public engagement network as part of the ICS structure. So I think it's just a note, Chair, if I may, and back to probably David's point when I presented the ICS paper, that there's obviously a link to unitary, but there is a pressing ask in the sort of near future, October, November, around developing whatever we think the function looks like. So I think in terms of the fora's futures, that would need to form part of the scope of those conversations. So it's not just a unitary conversation; it's a system approach.
Okay, look, I'm hearing some good feedback here that they do add value, but there's issues around equity of support and all the rest of it that we can look at. Can I, if you're happy with me to take this offline and bring a paper to the board in January, taking some of Tim's comments on board as well, to see that we have a structure that will survive the transition into the new unitaries, and we don't sort of run around on the 1st of April wondering what on earth is going to happen. Would that be acceptable?
I think that sounds really good, Nick. I would also just emphasise that support is, and where we identify that support from as well, and what that support looks like, is a really important part of that discussion too.
Okay, thank you, Mary. So, so on behalf of the board, then I'm happy to take on that task. Thank you. That moves us on to item 19, which is any other business. So, anybody for any other? Tim.
Yeah, sorry, Nick. It was just a reflection following Adam's presentation, just to sort of offer of support in terms of Richard's challenge into the meeting around sort of system solutions. So we do have, as colleagues have alluded to, a people board, and so I think the element around workforce and people around the AMP issue, I think, needs to be brought to their attention, and whether I can do that or yourself can do that from a practical perspective, Nick, as chair from this meeting, to raise the issue, I think just needs to be made explicit. So yeah, I'm happy to take that as a joint action from this meeting. But also we have an emerging system financial leadership committee, very much working in a different space, and I wonder if we can quantify the workforce and people issue in terms of actually, you know, if we had a system in place. There is a gap though in financial resources that, again, we take an explicit action as chair and myself as the system lead on the meeting today to highlight the issue.
Okay, thanks, Tim. Yeah, I mean, I'm happy again. Pick that up offline if you want. That's really good. Any other? I mean, just again to reiterate, Jonathan Ireland. So Jonathan's been with us, board member since 2015, played a vital role, etc. So Jonathan, on behalf of the board, thank you very much. And with that, unless there are any other AOBs, and I'm looking down for hands raised, I can see none. Basically, the take-home message has got to be keep on keeping on, guys. A tremendous amount of good work is going on, despite and including the response to the pandemic. So thank you all, and we'll meet again on the 14th of January 2021. So let me be the first to say Happy Christmas.